beyond. And we've got with us Dr. Don Colby. He joins us for the second day here, switching roles. Yesterday you were being interviewed, but now you will be helping me doing the interviews, the interviewer. So we'll start right with the first topic of discussion, and that is ending the epidemic through prevention in priority youth population. Let's bring on Dr. Renata Sanders, who's from the Johns Hopkins University School of Medicine in the USA. Hello, please join us. Do take a seat right here.
Thank you.
สวัสดีค่ะ Warm welcome to you. Do tell us, how close are we to ending the epidemic in adolescence?
I think we've got a lot of work to do.
All right.
As you may have seen in my talk about, in Thailand, about 47% of all new HIV infections occur among adolescents and young adults, so 15 to 24 years old. And so if we're going to get to zero, we have to get that number down. And in some Pacific and Asian countries, it's even higher than that, right? So as much as 60% of new infections. So we have to, if we're going to end the epidemic and reach our targets, we really need to address adolescents and young adults, because they're they're our future,
Right.
And they're where the epidemic is.
So I might ask you a question. I'm a parent. I have two
Yes.
teenage sons,
Yes.
so I know that adolescents are different.
Yeah.
But maybe you can tell us in terms of HIV prevention. So what's different about adolescents than adults that we should be thinking about if we really want to get to the goal of ending AIDS for everyone, including adolescents?
Yeah. And I have an adolescent myself and a pre-adolescent, so I'm right in the mix of everything as well. I think that there are some different components that we have to address, and I tried to focus on a few of those today, particularly thinking about the development of the adolescent and where they are, but also thinking of the context that puts them at risk, right? And then thinking about where are some key points that we could intervene to address those periods of vulnerability and risk. I think that comprehensive sexual education is one particular area that needs to be addressed as far as trying to engage youth into testing. So if we hope to get them onto PrEP, pre-exposure prophylaxis, we have to, the step before that is for them to be tested, so we know their status. In order to get them tested, they have to know that there's a test that exists and that they should be tested, right? And in order to do that, then they have to also understand their risk and what puts them at risk.
Right.
And not just here, but in the U.S., sex is a very taboo topic, particularly among adolescents and young adults and young people. And so we often try to avoid that subject matter.
Right.
I think that there has to be a couple strategies from a comprehensive sexual education, both in the home and in the schools and in the community, right? So it can't just fall on one group or the other.
Right.
But really introducing early on conversations around what it is, understanding even before that one's body, how it changes, what's appropriate touch, inappropriate touch, right? And then also thinking about relationships, what's healthy relationships, unhealthy relationships, and then giving youth the skills to be able to protect themselves, negotiate condom use, understand what condoms are, how to use them, when to use them, and then understanding what are some other options as far as prevention is concerned, including PrEP and testing.
Yeah. So you mentioned that that in terms of talking about sex, most people would rather avoid it, and I think that's true of most even doctors and healthcare professionals as well in the Western world and here in Asia as well. But would you have any advice for, say, providers in Asia? This might be physicians or nurses or a lot of times our counselors or our health professionals, but not necessarily a physician or nurse. What is maybe the first steps they can take to sort of get over this barrier of trying to avoid it and taking it head on? Maybe.
I think there are a couple of both structural and non-structural approaches. So I think structurally, as much as possible, if you can make it routine, part of primary care provider visits. One thing that has been very helpful and that has been shown to be helpful is having some sort of intake questionnaire can sometimes make providers feel a little bit more comfortable and a little bit more at ease, right? As well as youth.
So you mean giving a questionnaire before they actually meet the provider?
Before they meet the
maybe
provider,
while they're waiting.
yes, while they're waiting. And actually, mostly in adult data, but the asking about sexual orientation and gender identity has been shown to be more acceptable on a paper form, like on a survey or questionnaire, than face-to-face. Because both the individual and the provider feel a little uncomfortable, and it's often comes across. And so it's much easier to have that intake questionnaire at the beginning, where the individual can just complete it, and then the provider can say follow-up questions, right, around those. So I think, that's a structural, that's like a concrete way of making it more systematic. Making sure everyone has it. We have one that asks about key areas, and so we try to focus also on a comprehensive approach, meaning not just about sex or sexual orientation or gender identity, but comprehensive to the adolescent. So we use in the U.S. something called the HEADS framework. It means HEADS, H is home, talking about the home environment, education, talking about school, what's going on at school, and eating, and A, activity, talking about what sort of activity they're involved in. By understanding the context, you understand where there may be periods that may place them at vulnerability, but also protect them, right? If they're active and they're involved in sports, they may be less likely to engage in risk behavior, right? Asking about drug use is the D, sexual orientation, sexual identity, and then also gender identity. So using a framework, so not only an intake form, but also a systematic framework, so that the provider feels comfortable just kind of going through questions. But when they're asking the questions, it's really important, how we're looking, right? Where I'm facing you, I'm making eye contact, body language, right? It's really important to, create a safe space and an inclusive environment, right? And so teens know if the person they're seeing actually sees them, right? And so what do I mean by that is, like, teens know if you care, right? So if they go to see a provider and the provider is making kind of faces that are not accepting and welcoming, they're going to shut off. So teens will not be open to someone who is not willing to, have some open body language. We surveyed youth and found that youth are looking for visual cues that say this is a safe space. It might be a flag, it might be a sign, it might be a lapel pin or something like that. The body language is also critically important. Right. So I think that those are some concrete ways, and then of course making a comprehensive history around sex and sexual history and sexual education is also important, and then having youth-friendly resources at the end of the visit. So we remind our trainees that you don't have to do everything at that one visit. But you can refer to resources, right? So I shared the Advocates for Youth webpage, an example, because you may not have time to talk about getting ready for sex or am I ready for sex, right? But you can talk about how it's important to wait because that's healthier for them, and then you can refer them to resources that actually help with that.
So you mentioned gender identity as one of the things to talk about in every phase there. That may be more difficult for some providers to ask about, even in sexual behavior. Do you have any way to sort of ease that topic into the conversation, or an easy way to ask that question?
I have a workshop this afternoon. The two-step method is actually the better approach. So really asking one about what sex you were assigned at birth. And then asking two about how you identify, and then giving examples. And so I'll often say, some of my patients are born male and they don't identify as male. They identify as female. Have you ever felt that way? So providing that example, I think also when we use that language of some of my patients, some of my other patients I care for, or youth that I've provided care for, also normalizes it. So really makes it seem like what they're experiencing. Remember, the adolescent is wondering, am I normal? And they think that they're not, right? They think they're unique, they think they're different, and so they think that everyone's looking at them. So they're looking to the provider to really tell them that they're normal, that other youth are experiencing similar feelings. And so using that sort of two-step approach, because if you ask, are you transgender, you're going to get strange looks, like, I don't know what you're talking about, right? Some people haven't even heard that term, right? Some people have, right? So, but really, that allows an opportunity to have a conversation and then to unpack it a little bit.
Thank you so much, Dr. Sanders, for being here.
Of course,
talking
thank
to
you.
us. Thank you.
Thank you. Thank you very much.
Just talking there on how to end the epidemic through prevention in priority youth population. She did bring up the HEADS framework and finding a safe, supportive, caring and understanding space. I think this is very important so that they do come in and seek help, seek advice. All right, we were actually supposed to talk about effective responses and harm reduction for problematic chemsex, but unfortunately Dr. Matthew Mimiaga still stuck inside the conference room, so hopefully he will come.
We'll get him out.
But we're going to skip to Dr. Paul Thisayakorn first, and we'll talk about mental health in people living with HIV. So Dr. Paul Thisayakorn joins us from Chulalongkorn University. Sawadee ka. Thank you for joining us here.
Hi.
All right, please.
Yeah. So it was a very interesting talk that you gave today, and I'm an HIV provider, so I think of things from the HIV perspective. And I always thought, well, HIV is special as a chronic disease and has more mental illness than other chronic diseases. But actually, you said that's not necessarily the case.
No.
Yeah.
No.
So how does like HIV as a chronic disease interact with mental health? Is it the same or different as other chronic diseases? Should we think of it differently? Should we think of it the same?
Same and different.
Okay.
So, HIV, physical illness, and mental illness, we conceptualize it as the illness of bidirectional relationship. Means the HIV can cause the negative impact on mental health.
Right.
And mental health can also lead to the negative outcome of the HIV.
Right.
In several levels, like biologically, the brain, the virus can infect the brain. The virus can activate and cause trouble with our immune system, which the depression or anxiety or some of the psychiatric illness can also be affected by the abnormal of the brain and abnormal of the immune system, for example. On the other hand, when the people carries diagnosis of major psychiatric illness like schizophrenia, bipolar depression, it leads them to have less capacity to prevent themselves from getting the infection, or have more limited capacity to compliant with the antiretroviral regimen, which can lead to the worsening outcome of the viral load control or CD4 control. So once we appreciated the bidirectional relationship between these two, and once we pay attention on both HIV standpoint and mental health standpoint, I think it is when we can pursue the good outcome for our patients and communities.
Yeah. So during your talk, you mentioned some different ways that people can screen for mental illness. Would you have any recommendations for HIV providers, doctors, nurses, people who work in the HIV clinics? How should they be screening for mental illness, and when should they be sending their patients to you, the mental health care provider?
I see. So in the literature, there are so many screening tools that can be used and has been already studied, validated in the HIV population. For example, the Patient Health Questionnaire 2 and 9, the Hospital Depression and Anxiety Scale is the scale commonly used in people with mental health and the medical illness. The Beck Depression Scale is the scale that we use a lot in psychiatry. But in some guidelines, in some regions of the world, they recommend to use what we call Patient Health Questionnaire 2, PHQ2s, because it is fast, it is easy to use and simple.
It's only two questions, right?
Just
very
ask
quick.
2 questions. And if 2 is positive, then go to 9, PHQ9s. And then we have kind of clearer picture that this patient might suffer from clinical depression.
Okay. And then what criteria should the HIV clinics be using to decide when should they send someone to a mental health care provider?
There is no clear criteria. It depends on the communication between the HIV clinic and mental health clinics, because you know that both of us are quite busy, right? So the criteria is not as important as your feeling as the provider, the doctor, the nurse, the social worker. When you talk, when you touch base with that patient, and how do you feel? How do you sense the severity, the need that they should pursue in that particular case? Trust your feeling, trust your gut feeling. If you feel like this individual needs help, I think it's validated enough to send the patient to the psychiatrist. But again, the tools, the screening tools, or some of the risk factors like history of abuse in the childhood, substance use history, suicidality, active psychotic symptoms can be the red flags that you urgently need to send the patient to see the psych.
Right. So in thinking about treatment, when you're treating mental health disorders with a person with HIV, is the treatment any different than somebody without HIV?
The core treatment strategies are the same. That there are a little tips, a little points that we need to be cautious. The core principles of treatment is to provide safety, provide empathy, support, connection. Thinking about both biologically, psycho and socially interventions that can help. But in the HIV, we may also need to think about the brain process of the virus, the opportunistic infection, the HIV medication itself that sometimes can associate with some mental health issues, the substance abuse issues. So we can provide a safe and efficacious treatment. And we also need a team. One psychiatrist cannot give the good care for the HIV people because some of the individuals, their problems are so complex. So we need a team of HIV doctor, social worker, nurse, family, school, friends. Then we survive.
Right. So in HIV, we often talk a lot about prevention. We're talking more about prevention of infection or infectious diseases. But is there anything that the HIV clinic can be doing, or even family or community, to prevent mental illness in people with HIV?
I think what you have already done about to the stigma, the HIV, is already the stigma, the mental health. Because people living with HIV deal with stigma. People living with mental health also deal with stigma, and it is double stigma. So we keep working together to reduce the stigma. Early detection of depression, anxiety is the key. Connect to the evidence-based treatment to the local psychiatrist or the psychological units that are close to use, and maybe start to provide more information about how mental health interacts with the HIV status.
Appreciate that so much. I mean, sometimes it's very much overlooked that people living with HIV also suffer from mental illnesses. So we do appreciate you coming in to share with us. Thank you to you, Dr. Paul of Chulalongkorn University. And I also have to thank you as well, Dr. Don Colby, for helping me out here. Once again, Dr. Don Colby, he joins us here as Senior Clinical Research Physician at Search Thai Red Cross AIDS Research Center. And I know that you're also very eager to listen in to the other presentations, so feel free to do that. But don't forget, we're back here again tomorrow as well.
Okay.
ขอบคุณค่ะ ขอบคุณค่ะ Now, talking about tomorrow, we have plenty more to be discussing right here. Our experts, our gurus will continue to be joining us. We'll be talking about the art of initiating ART and also the art of managing HIV resistance, and also continuing with people living with HIV and how do they age healthily. We'll be discussing those topics tomorrow. But for now, we will bring on 2 more guests, and we will be talking about challenges in detection and treatment of multi-drug resistant tuberculosis, and also updating management for preventing and treating cryptococcal disease. And we'll bring on our guest interviewer. She joined me earlier today, Dr. Thisayakorn Chuchottaworn. She is from HIV-NAT. So, ladies and gentlemen, let's welcome back Dr. Thisayakorn. Sawadee ka once again. Lovely to have you back here.
Yeah.
And I know that so much information is being shared inside the conference room, so really appreciate you skipping that and coming here to discuss deeper regarding the topics that were already presented inside the rooms. So we're now going to talk about and focus on the challenges in detection and treatment of multi-drug resistant TB. Dr. Charoen Chuchottaworn, the Chief of the Division of Respiratory Medicine at the Chest Disease Institute of Thailand, joined us. Sawadee ka.
สวัสดีค่ะ
Good afternoon. Pleasure to have you here with us. Challenges in detection. Can you give us an overview of those challenges, please?
Currently, the technique we use for the detection of tuberculosis or diagnosis of tuberculosis, which we use old technology which discovered 140 years ago. But now we have a new technique which is a molecular test to provide the diagnosis of tuberculosis, and also at the same time we can detect the resistance. But the problem of the new technique is that we need not a special lab but a machines, instrument to do the molecular technique, and it's expensive. And also the test kit, which is expensive. But we are lucky that the Global Fund, which is a foundation that provide the money to support the control of some serious diseases like malaria or TB or HIV. The Global Fund provide the money to purchase these machines and to provide to the poor country to get the people, the patient more access to this test. But we still have a problem that it's still not enough. That's the problem with the budget,
Yes.
you see. And 2 days ago, I just got a mail from WHO that currently, or not currently, they will recommend to use this molecular test as a primary tools to diagnose TB.
primary tools okay
It's good for the patient,
yes
but it's not good for the administrator
Yeah.
because they still have to
but it's
find the money.
still challenging
Yes.
yes
It's a challenge.
Yeah, I got one question from our infectious disease colleague who have to take care of MDR TB patients about
Yes.
the discrepancy about the gene expert and lipo assays. So in the guideline, they recommend to use the gene expert for screen the MDR. If the gene
Yes.
experts come out that we have a rifampicin resistant, so we have to change the regimen to MDR TB regimen. But if in that time we also send the lipo assay. But if the lipo come back with negative, what you will do in this case?
So you have to join my talks this afternoon
Okay,
because I will
I
talk this.
definitely enjoy.
Yeah. I will talk this issue in my talk because there's discrepancy between the 2 molecular techniques.
Yes.
So the point is that because of the molecular test is very sensitive, the principle is that if we use the very sensitive technique or tools to detect that resistance in a population which has a low prevalence of that resistance, you will get a very high false positive, something like that. So currently the point is that if you test you do the expert in as a routine, you get a very high false positive rate of resistance because in general the prevalence of resistance is low in general. So my recommendation is that you have to retest it. It's not the real discrepancy, but the second test of the lipolysis is just like a confirmation of the first test, whether it's true or not. So in the guideline, even in the WHO guideline, just mention this part in a small paragraph that you have to worry, you have to take worry about this. If you want to use it as a routine practice in the low prevalence populations. So that's the point.
Okay.
I will show you the data and how to calculate this.
I will look forward to see that. And another question, because we are facing side effect from injectable drug in the multi-drug resistant TB regimen. So how we can manage this
Stop
problem?
using it.
Stop.
Direct towards the stopping. The last guideline early last year in March 2019, the WHO recommend to fade out the use of the injectable drug because in the review or in the publication in 2018 from nearly 12,000 MDR-TB patients show that the role of this aminoglycoside was not very good. So in the new classification of the WHO, they put the aminoglycoside at the end of the table. So it means that
it's not preferable.
It's not very good drug for the MDR-TB. So, and last month, the WHO just launched out the new recommendation to stop using the aminoglycoside for the MDR-TB and substitute the aminoglycoside with the beta-quilin, the new drugs for the TB. That's good news.
Yeah, that's good news. But it's bring another question that beta-quilin will be available in Thailand soon.
Sure. Currently, we have 200 dose for 200 patients now, and we the TB control program plan to purchase another 1,000 cases.
Okay.
So it means that our patient can access to this now, and it's very cheap now. Not very cheap, but affordable price.
Affordable. Okay, it's very good news.
Yes.
Yeah, and the next question is about the prophylaxis in MDR-TB contact, the export to the MDR-TB case. How we gonna manage this population and how can we prophylaxis them?
We don't have the data prove that which drug is effective in preventing the MDR-TB contact to develop the MDR-TB patients. But we are waiting for the new study, the Phoenix study, which is use development a new drugs for TB. So I think that it will come, the result will come out soon, next year or something like that. So in that case, we can recommend you to use it. But currently, we just ask the clinician who take care of this group of patients that to cross-follow up this patient, whether they develop active disease or not. We don't have the effective, proven effective medication for this contact of MDR-TB patients. Like that.
Thank you so much. I really appreciate it that you're so eager to share and tell us more and more and more. And we definitely look forward and we'll stay tuned to your presentation, your talk later, and we'll make sure that there is lots of opportunities for the audience to ask you questions. Thank you so much. Thank you, Dr. Charoen Chuchottaworn, the Chief of the Division of Respiratory Medicine at the Chest Disease Institute here in Thailand. We continue now.
Yes.
We're now going to be getting an update of the management of preventing and treating cryptococcal diseases. And we have with us from the Faculty of Medicine of Khon Kaen University, Dr. Ploenchan Chetchotisakd. Let's welcome her here. So lovely to have you join us. สวัสดีค่ะ
สวัสดีค่ะอาจารย์
To share with us. First of all, could you perhaps give us an overview of your presentation, please?
Okay. In my presentation, I will give the update on the prevention, treatment of cryptococcal infection and also the adjuvant treatment. And lastly, is about the
timing to initiate antiretroviral treatment.
Now, for those of you who did miss Doctor's presentation, I'm sure that you can view it again on HIV-NAT's website, so you might want to log on and check out that presentation. But for now, let's get more highlights from what you delivered.
And as we know that the cryptococcal meningitis is a common cause of meningitis in sub-Saharan Africa, but do you think it's still a problem in Thailand or in this Southeast Asia region?
Okay, cryptococcal meningitis is a very severe disease. Right now, it's over 100,000 cases in the world. But as you mentioned, mostly it's in sub-Saharan Africa, but in Asia, it's also a problem. Like Thailand, it's the third most common opportunistic infection and the most severe infection.
Yeah. So that's why this cryptococcal meningitis is still important in Thailand. And do you think the MIC for cryptococcal is still necessary in clinical practice?
Okay. For the treatment, the main drug that we use is amphotericin B, flucytosine, and fluconazole. That is the three drugs that we use. But currently, the MIC determine is not necessary. Most of the guidelines do not recommend to do that. But absolutely, if you have this patient who are treated with the standard treatment and not respond, especially in the maintenance treatment, fluconazole, something like that, and then they have relapse disease. At that time, you should do the MIC.
So MIC is necessary for the refractory case. Okay, and what is your recommendation for the fluconazole dose in Thailand? Because we don't have flucytosine, right?
Actually, right now, our guideline is mostly based on WHO guideline. The treatment of cryptococcal meningitis divided into three categories. First one is the induction. The second is consolidation. And the third one is maintenance. In the WHO guideline, the dose of fluconazole is quite high. In the induction phase, they use the 1200 milligram per day.
It's very high for Thai population.
For Thai population. And consolidation, they recommend 800 milligram per day. And maintenance is 200 milligram per day. But if you look at the CDC, IDSA guideline, they recommend just only 400 milligram in the consolidation treatment and 200 milligram in the maintenance. For Thailand, we try to adopt because we do not have the full cytosine available.
Yes.
We have limited access to the full cytosine, but it will be available soon.
Okay, it's a good news for ID folk who treat the cryptococcal meningitis.
So we put the range in our guideline, in our new guideline, we put the range 800 to 1200 milligram per day for induction. So you can choose, it depends on the patient. Your patient is a very low body weight, you can choose the lower dose. But if your patient is more bigger, you can choose a higher dose. And also in the study, they also monitor of the QT. There is no evidence of the significant QT prolonged in the 1200 milligram per day group.
Okay.
We do have a bit more time if you do have any questions further.
Yeah, so I would like to ask you, can you give us a summary of the update in the new guideline for the cryptococcal meningitis?
Okay. For the detail, you can listen to my presentation.
Yeah.
But briefly, for WHO guideline, they have a new recommendation. They put 1 week of amphotericin B plus full cytosine 1 week, and then followed by 1200 milligram per day for fluconazole for another weeks, and then consolidation phase 800 milligram. For alternative treatment for induction, they use the fluconazole high dose with full cytosine. And another alternative treatment is the amphotericin B with fluconazole high dose for 2 weeks.
Okay. And what is the adjuvant regimen for the crypto that you will suggest?
This is a bad news. The study showed that either dexamethasone or sertraline, that is an antidepressive drug that used as adjuvant treatment for cryptococcal, show a negative study.
Yeah.
So there is no recommend to use these two drugs.
Okay, so now we are not have an adjuvant for the cryptococcal. Besides do the lumbar puncture to control the.
Oh yes, that is
Key point.
Key taking care of the patient since the cryptococcal meningitis, they have an increased intracranial pressure. So you have to repeat lumbar puncture.
Okay.
Right, thank you very much, Dr. Ploenchan. Now, could you please give us the numbers once again? How many people globally who are patients having the cryptococcal meningitis?
Over 100,000.
Over 100,000.
100,000.
And you mentioned that that's heavily focused in sub-Saharan Africa, but we do have
Yes.
patients here in Thailand, and you said that those patients are actually in quite severe conditions.
Yes.
So compared to perhaps some other illnesses and diseases, 100,000 doesn't sound like it's too big of a number, but I'm sure that it is something very serious and something that we should all continue to work towards bringing down to zero. And thank you very much for all the valuable information that you shared there, Dr. Ploenchan Chetchotisakd from the Faculty of Medicine of Khon Kaen University. Thank you. And also we do have to say thank you to Dr. Thisayakorn from HIV-NAT. Thank you. And it has been a pleasure. And I'm sure that you do want to get back inside the conference rooms because it is so exciting to be listening in to the experts, to the doctors who have so much to share. And that's why they've been wrapping up later and later inside the conference room. So thank you for taking the time to be here. Thank you, Dr. Thisayakorn. And that is going to wrap up the series of interviews for the second day of this 22nd Bangkok International Symposium on HIV medicine. We will be back with you once again tomorrow for many more sessions. So join us beginning 10:30. But for now, I'm Pachari Raksa Wong. See you tomorrow. Sawasdee ka.